in the front, and my dear fellow medical colleagues. I am Shaik Karimuddin Abdullah of final year MBBS Part 2 of Shadan Institute of Medical Sciences, here to present a case of Waldenstrom's macroglobulinemia, a coincidental finding in a case of carcinoma of buccal mucosa. Case history: a 50-year-old patient came with the complaints of a lesion in the oral cavity since 2 months. The patient was apparently alright 2 months back when he developed a lesion in the oral cavity on the inner aspect of the right cheek. Gradual in onset, progressive in nature, slow growing, painless lesion, bleeds on touch, associated with ulceration. Past history: no similar complaints in the past, known hypertensive and known diabetic since 5 and 3 years respectively, and is on medication. No history of seizures, bronchial asthma, tuberculosis or any other medical illness. Personal history: mixed diet, normal sleep and appetite, normal bowel and bladder habits, no history of weight loss, no addictions. Family history not significant. General examination: the patient is conscious, coherent and cooperative, well oriented to time, place and person, moderately built with pallor, no icterus, sinuses, clubbing, cutaneous lesions, lymphadenopathy or organomegaly. The vitals were stable. Examination of the general of the CNS, CVS, respiratory and per abdomen reveals no abnormality. Local examination of the oral cavity: a cystic lesion found on the right side on the oral surface of the cheek. Biopsy of the lesion was performed and diagnosed as squamous cell carcinoma. Surgery was planned and investigations were advised. On the pre-op, investigations revealed anemia, raised ESR and autoagglutination of the RBCs, which was seen on the peripheral smear examination. Mild leukocytosis was seen and normal platelet count. Other routine investigations were all normal. Special investigations such as Coombs test was negative and reticulocyte count was normal, which excludes autoimmune hemolytic anemias. Series of further investigations were done to find the cause of autoagglutination of RBCs. Further workup involving special investigations for cold agglutinins was done, that is that at 4 degrees Celsius was positive with 1:128 titers of cold agglutinin. Serum protein electrophoresis revealed M band in the gamma region. Urine was negative for Benz-Jones proteins, and immunofixation revealed monoclonal gammopathy of immunoglobulin M. The bone marrow aspirate was done with normal findings except for mild and focally increased lymphocytes, normoblastic and megaloblastoid erythropoiesis. Trephine biopsy was done with adequate and normal bony trabecular and intervening marrow showing 60% cellularity. Trilineage hematopoiesis and focal nodules of lymphoid and lymphoplasmacytoid aggregates. Skeletal survey was done. There was no evidence of any osteolytic lesions. This was done to exclude multiple myeloma. Immunohistochemistry with CD20 revealed a strong positive picture, whereas CD3 was with few positive cells. Differential diagnosis: monoclonal gammopathy of undetermined significance, lymphoplasmacytic lymphoma, multiple myeloma and cryoglobulinemia. Final diagnosis correlating with the clinical history and investigations: anemia, autoagglutination of RBCs, presence of cold agglutinins, IgM monoclonal gammopathy, bone marrow aspiration and biopsy findings, and IHC interpretation revealed Waldenstrom's macroglobulinemia. The treatment for buccal mucosa lesion, that was squamous cell carcinoma, a wide surgical excision was done. MRI was done prior to the surgery to exclude all the exclude the local spread. No post-op events with good healing. For Waldenstrom's macroglobulinemia, as the patient was asymptomatic, there was no need of therapy. Initiation of therapy is not based on the level of IgM protein, but instead it is based mainly on the symptoms and signs. The patient is advised for a regular follow-up. Lymphoplasmacytic lymphoma. The WHO category of LPL incorporates Waldenstrom's macroglobulinemia but excludes other specific lymphoma subtypes with plasmacytic differentiation. The secretion of IgM is a common feature. It is a pleomorphic lymphoproliferative disorder characterized by the elevated levels of monoclonal immunoglobulin IgM secreted by the malignant B cells, and therefore paratrabecular lymphoplasmacytic infiltration in the bone marrow. History of the disease: it was originally described by the Swedish oncologist Dr. Jan Waldenstrom in 1944. In the original description, he described 2 cases with oronasal bleeding, lymphadenopathy, anemia, thrombocytopenia, raised ESR, high serum viscosity, and infiltration of the bone marrow by lymphoid cells. He interpreted the symptoms to be related to the hyperviscosity due to the presence of high molecular weight serum protein, whereas the patient here was asymptomatic. Incidence is 3 cases per million persons per year. Commonly seen in the whites. In United States, each year there are 1,500 new cases diagnosed. Approximately, it accounts for 1 to 2% of all the hematological malignancies. Median age at diagnosis is 63 to 68 years. Symptoms is mainly due to the hyperviscosity, such as weakness, fatigability, visual disturbances, blurring of vision, hemorrhagic manifestation, neurological symptoms, and weight loss. Most cases involve the bone marrow. Extranodal sites are hepatomegaly, splenomegaly, lymphadenopathy, anemia, IgM, hyperviscosity, neuropathy, and coagulopathies. Peripheral smear reveals anemia, rouleau formation, and autoagglutination of RBCs. Bone marrow, infiltration predominantly by the lymphocytes, variable number of plasmacytoid lymphocytes. Treatment, the protocol has not yet been established. Alkylating agents such as chlorambucil, cyclophosphamide have been used. Steroids, prednisolone, monoclonal antibody, rituximab, plasmapheresis for hyperviscosity, and bone marrow transplantation have been tried in United States. It is not a curable disease yet, but a treatable disease. And the association between lymphoid malignancies and non-hematological malignancies has been documented, such as hepatic carcinoma, lung carcinoma, renal cell carcinoma, and carcinoma larynx have been seen in the world. Whereas this case with the buccal mucosa carcinoma is the first case reported so far in the world literature. It could be due to a common genetic mutation or immunomodulatory role of the first malignancy, that is Waldenstrom's macroglobulinemia progressing to squamous cell carcinoma. It is due to disease-related immune suppression. The take-home message, it is mainly, it should be considered in the differential diagnosis of unexplained anemia or pancytopenia in an elderly patient. It shows the importance of simple procedures such as peripheral smear examination, which lead as a breakthrough in the diagnosis of indolent hematological malignancies, and the increased risk of secondary malignancies in such cases needs a careful oncohematological surveillance. I would like to thank my guide, Dr. Mahjibin Salma. Thank you.
Carcinoma and WM, Waldenstrom microglobin.
Yes, because of the disease-mediated immune suppression due to Waldenstrom's macroglobulinemia, there could be incidence of secondary malignancies in such cases, which has been seen in the world.
Okay. Another question. Does early diagnosis changes the prognosis of the disease? Early diagnosis of WM has got anything to do with the prognosis of this disease? You just said it is treatable but not curable. So can you?
Yes, when it is a treatable disease when it manifests with the features of hyperviscosity. But as such, there is no cure for WM. The protocol has not been laid down. Though trials have been done where steroids or monoclonal antibodies such as rituximab or alkylating agents or purine analogs have been tried. Bone marrow transplantation has been done. Plasmapheresis has been done for hyperviscosity.
Thank you.
Thank you.
Just a second.
Yes, there was a monoclonal gammopathy.
Okay.
No, he told M.
Can you repeat the question for the audience?
What does M stand for?
Monoclonal. There is a single clone of there is a single clone of cells which get proliferated in this.
Which immunoglobulin level will rise in multiple myeloma?
In multiple myeloma, also IgM levels are raised.
IgM.
Yes, mainly.
IgM.
There is slightly raised in IgG and A also.
Anyone else? The final years, the third years? Okay, thank you. We shall move on to the next case.